Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
What percent of people you think regularly give their kids vitamin supplements?
Repeat that question.
How many parents regularly give their children vitamin supplements? What percent?
Oh, I'd say very few.
Any other thoughts?
10% maybe.
52%.
Ooh,
The
gracious.
reason they do it is because they think their children don't eat right. And so they're trying to make up for it because they eat what they want to eat and they don't eat things that are healthy. Vegetables and fruits and those kinds of things are commonly eaten. So parents think they can help them by giving them vitamin supplements, although there's really no substitute for a balanced diet. We as adults don't do, we do better than they do, but and the discussion about supplements has been ongoing, but so far there's been no demonstration that you don't have a vitamin deficiency, vitamin supplements are any good for you. That doesn't stop people from buying it anyway. That was interesting on both of those things. Okay, any other things I'll bring up, John, you want to start off? Let's think about many health topics.
Dr. Callender, your microphone seems muted a little bit. You know, it's a little hard to.
It's muffled.
It's muffled.
Yeah.
As high as it can go.
Oh boy.
It's about the same.
Oh boy. Wow.
Tina,
Okay.
while we're waiting, you want to tell them about the Chris Klug thing I nominated you for? John Freedom, can you hear me? Oh.
My God.
Tim, can you hear me?
Yeah, I can hear you.
You want to tell them about the Chris Klug bounce back thing I nominated you for?
Glory.
Yeah, I know very little about it. I saw it and I bypassed it. And Dr. Callen said, "Hey, boy, you better get and put your name in." And I said, "Okay." You said, "Have your wife do it for you." I said, "Okay." So I, put in my nomination for Give Back,
Bounce back.
Bounce Back Award. Yeah.
But Chris Klug is a liver transplant recipient who was a Olympic skier, I think. And he has been giving 2 bounce back awards a year to transplant recipients who have been in an unassuming way, as John Tatum has, been going about their business without people even knowing that they have had liver transplants. And since John has had his for more than 28 years, And because he's been such an incredible uh, public citizen with his work with the retirees and with our group and with so many other things, and including to his gifts as a musician, which he's used so liberally for all people. I thought he'd be a great candidate for the Chris Kluger Award uh, because he typifies the bounce back qualities that Chris Kluger is looking for. So with that in mind, with great resistance and with great reluctance, John agreed to do it. Actually, Carol twisted his arm mightily in order to get him to accept the nomination for that award. Anyway, it'll take time. They don't make the announcement until June sometime. But anyway, this is his name, and sometimes people who are great like John are unappreciated because they give of themselves unstintingly without any expectation of any recognition. They do it because they love God and they want to give the best to the master. And so he's done that for almost 3 decades now, and we appreciate his great work. But I think it's important for everybody to know the great work that John Tatum has done for the last 30 years. Okay, John, any other comments you want to make since you made none? Okay. Fear of God and humility, giving riches and honor and life. So
I just want to thank you for pulling my coattail, as they say,
yeah,
and giving me the idea to go for it.
yeah.
I appreciate the boost.
You richly deserve it. Okay, this is
I'd like to say too that John he's just a chip off of his family, because that spirit of giving is start way back in his family.
That's true.
yeah. Well, he's a great example of it. So great role model.
Father, grandfather, yeah.
Go to his children, grandchildren, and all those who associate with him, like us. Yeah. Anyway, this is an interesting article that talks about not the common things that you think of that raise your blood pressure, because we know all about salt and stress, but sometimes you're not aware of the other things that can cause your cardiovascular system to be compromised. And high blood pressure is a silent killer. It's a great term for it because without symptoms, it can lead to what you see: heart attack, stroke, heart failure, kidney disease, vision loss, sexual dysfunction, heart disease, angina, which is pain, chest pain, and blood vessel disease, peripheral circulation problems. And half of the United States have high blood pressure, but only 1 out of 4 really has it under control. One of the things that we have a screening process, and we screen people for high blood pressure and for albumin or protein in the urine. And about a third of the people we encounter have high blood pressure or protein in the urine. But what is common about those people with high blood pressure is that at least half of them know that they're hypersensitive, but they don't take their medications. And so this is then as one of the biggest problems is that if you know you have high blood pressure and don't take the medication, what happens is that you wind up 20 years later with kidney disease or heart disease, any of those items that we just talked about. And so it's important not only to take your blood pressure taken, but then to take blood pressure medicine to keep your blood pressure under control. And when we talk about under control, they consider 120 to 130 as pre-hypertension, and 120 over 80 is the idea, but 140 over 90 is the real deal. But it's recommended to stay around in the 120 at least.
I have a question, Dr. Callender. Why do people not want to take their blood pressure medication?
Well, I guess a number of reasons is that one of the main things is that what makes you you is your habits that you have. And so if you don't have a habit of taking your medications once or twice a day, then you have a tendency to disregard it. And that's not one reason. The second reason is the side effects of the medication. Sometimes there are side effects of the medication that you don't like. Sometimes there's inability to have an erection. Sometimes uh, it interferes with sleep. Sometimes it interferes with other things. So that side effects is one reason. And the other reason is just people just don't have good habits, healthy habits. Those are two of the comments there.
Darryl to play for boy.
Those in the audience who are not taking the medication may say,
Yeah, I gotta be there by 10.
if you fit into that category,
Bethesda.
medication, or you forget to take the medication. Nobody fits in that category, dude. That's good to know. Okay, well, this is one of the sleep obstructive sleep apnea, which is a situation that exists where you, because of your inability to breathe at night, you stop breathing, and when you stop breathing, your CO2 level goes up and your O2 level goes down. As a consequence, you don't have good quality sleep. Therefore, one of the things that happens is that your blood pressure goes up because you're struggling and fighting to breathe. And so obstructive sleep apnea is more common than black. And so that's something. How do you know you have it? The only way you know you have it is you have a partner. And the partner tells you, snore at night. And sometimes when you snore, you just stop breathing. And this results in fatigue. And so the only way you can make that diagnosis is if you have a partner or if you have a sleep test. They take you in a room and let you sleep all night, and they monitor your breathing, and they monitor your oxygen levels, and these then result in uh, causing high blood pressure. And the treatment is CPAP, it's continuous positive airway pressure machine that you sleep with, and if you use this overcomes the hypoxia and hypercapnia, high CO2 levels that cause the hypertension.
Dr. Callender, yeah, I had that that opportunity to suggest that my spouse might have a sleep test, sleep study, because she snores and will wake me up, and I'm a very light sleeper. So when I told her she needs to take a sleep test, she said, "Well, you snore." So I went ahead and got the sleep test. I found out I have mild obstructive apnea, and I got a CPAP, and I use it nightly. I have very, very high ratings for the use of it. And she eventually, after about a year, went and had her sleep study, and they found out she has severe obstructive sleep apnea. So she has a CPAP machine now as well.
It's very common in black folk, and is a cause of hypertension as well, and it causes other complications, especially fatigue, easy fatigability, and in addition to the cardiovascular component. And the common
Dr. Callender, I saw an article about they have a way now that you don't have to use the machine. You can there's something that they can implant in you. Have you heard about that?
No, I haven't. So if you find that article, send it to us. We can look at it.
Okay, I will.
Because the CPAP is the accepted way of doing it if you don't have that implant to speak of.
Yeah, I have sleep apnea, but a lot of times I'll fall asleep before I put the daggone thing on.
Okay. Any other comments about this? Because I think it's a common in our ethnic group, and it's one of the causes of hypertension and causes mortality, causes death in our population. So CPAP in general is the answer. Then secondly, of course, is we're all aware of the air pollution. And the climate issue is something that we talk about now almost daily. And so that along with obesity results in high blood pressure. Now, of course, we talk about filtering the air, and of course, that's true for those people who can afford the filters. But I think that along with exercise will also help. So, and you know, the people in the urban areas are more subject to this problem than people in the rural areas. And but look at this study that shows that 99% of the globe live in places where air quality does not meet guidelines. Yeah. So, and then of course, noise pollution as well. And the third thing they identify is black licorice. I don't know how many of you know about it, but it causes sodium retention and also hypochloremia. Anybody like black licorice? There's some people who like it. I never have tried it. Anybody in this group like black licorice?
No, I don't like it. My mother liked it though.
Hmm.
I don't like licorice.
What form does black licorice come in? I mean, I've seen the candy, but I've never seen anything else that has black licorice in it.
That's the candy. Yeah. Yeah. And some people like it a lot. Yeah. Number 4 is alcohol. And heavy drinkers can have their blood pressure elevated. Of course, we know that, as the Bible says, one drink is good for the stomach sick, maybe, but then when you get up to 3, 4, and 5, then that causes problems. So, like, say more than 3 drinks a day for women, 4 for men. Can cause hypertension. Cutting it to 1 drink can lower the blood pressure. There are 2 components to the blood pressure. The systolic, as you see here, and the diastolic. And you can see the numbers there that correlate with stage 1, stage 2, and so forth. Any comments about this? Any questions about this? It's important to keep this in mind. Well, I think the last time somebody asked about what is the low blood pressure. I think blood pressure below that 100 suspect. Although there's some people who normally run blood pressure is 90 over 60. So, and they are perfectly healthy. But it's a cause for concern. Anybody here in that group who run 90 over 60? Yes, most of us run higher.
I get conflicting things when I'm at home and take my blood pressure. It's like 120 over 70 or something like that. But when I go to the doctor, I get that white coat syndrome, the first one. and then we go on and talk and something, and then they take it again, and it's back down to it'll get to 130 over something. But I hardly ever get 120 when I'm at the doctor's office.
Well, I think that the best blood pressure is the pressure you take at home when you relax and sitting down for 15 minutes or so. And so that is the most important blood pressure, the pressure that you take when you relax. And if there's a difference between that pressure and the pressure at the doctor's office, then you should disregard the doctor's office. And then you routinely take your own blood pressure at home twice a day, and then you record it and take that in so the doctor can see it. Because white coat hypertension is a syndrome that is well recognized. Then, of course, number 5 is the non-steroidal anti-inflammatory drugs like Advil and Aleve. Their side effects so that they can also raise the blood pressure. And there's so many over-the-counter decongestants also cause hypertension. So, and then they mentioned these supplements like ginseng and ephedrine also raise blood pressure. So these are sometimes common medications that we take that we don't recognize can have a side effect of raising the blood pressure. Doesn't mean it always happens, but means that it can. And so, how would you know? You take your blood pressure after you take the medication and see what happens. Commonly, the decongestion when you have trouble breathing, you take that's a common they use in some of the cold medicines. Have some of that. So if you're hypertensive already, this is something to be aware of. Now we've always talked about salt. We don't talk so much about sugar, although Darryl does. But most people aren't aware that sugar is a substance that is common in everything. I don't know if we have anything that's never like sugar, but because of the release of insulin, you can have your blood pressure elevated. Then number 7 is smoking. And of course, I don't know too many people around that smoke, but some of us used to probably. But that's a problem that is associated with cancer, narrowing the blood vessels, and increased blood pressure and heart failure. So smoking is, there are many reasons why smoking is not good for you. You know, if you're smoking, you need to have that habit eliminated because it contributes to ill health. And then there was an article recently in the Washington Post where this young person had high blood pressure and they missed the diagnosis of primary hyperaldosteronism. But this is a situation in which the potassium can be low and the aldosterone level high, and this results in hypertension, which can be treated by medication. Now, this is the part where we talk about the fact that being overweight is one of the biggest components of high blood pressure. Although people with the worst blood pressure I've ever seen have been very thin. But that doesn't mean that being overweight does not cause hypertension. Yes, it does. But, that alone is the many other things that contribute to it. And this concludes by saying that taking your blood pressure at home is a great idea. You get a blood pressure monitor and take your own blood pressure once or twice a day when you're relaxed and sitting up and taking a read. And then monitor and record it. And that's one of the best measures.
Dr. Callender, you know, this is a sad story, but there was a guy who stopped taking his blood pressure medicine. And the reason why he stopped taking his blood pressure medicine was because it caused him to have ED. And so he
What?
died.
What is ED? What is ED?
Erectile dysfunction.
Oh, okay. Yeah, there are many stories like that, John. We had a number of patients. I remember we had a patient who thought he had AIDS. They had gotten an inaccurate lab test and told him he had AIDS. So he thought he was going to die, so he started taking blood pressure medicine. He had a stroke and died. And so it's clear that there are many reasons why people don't take their blood pressure medicine. But nowadays they have so many blood pressure medicines that if one blood pressure medicine causes you side effects, you all get another blood pressure
Right.
medicine that won't cause you some side effects. So that excuse, in the old days, when I first started out, they only had one or two medications for blood pressure. Now they must have about 20 different medications for blood pressure. So if one doesn't work, you and your doctor try to find one that is associated with fewer side effects. Because your story is not isolated. Many black men would rather die than not take the medication if it's going to cause inability to have an erection in the heart or anything. Used to call it in the old days.
Dr. Callender. Hello?
Yes.
Yes. Talking about this blood pressure. A friend of mine went to the doctor about 6 years ago, and then he was prescribed blood pressure medicine, lisinopril, and so another one, I think metoprolol. So he took it for about 6 months to 9 months, and then stopped. And then each time he goes to the doctor, they keep on prescribing the same thing. But when they check his blood pressure, his blood pressure is okay, normal, 120/80. Anytime for more than over 4 years now, he has not taken any of the prescribed medicine. But his doctors keep on prescribing the same medicine for him. Why is that?
That is poor communication between the doctor and the patient. Because the patient telling the doctor he's not taking medication any longer. And because one of the first things you do when you have high blood pressure is address the non-medication ways of controlling your blood pressure, which means that you should cut back on your salt and sugar intake, exercise, and lose weight. And very often, those things alone will lower the blood pressure. And it is only after you've done that and that's failed that you need to take medication. And if you stop taking the medication and your blood pressure is okay, you should communicate that to the doctor. Because I think one of the worst things that can happen is for the doctor and the patient not be communicating.
Dr. Callender, shouldn't that patient also take to the doctor a blood pressure history?
Blood pressure what?
History.
Yeah, well, I think it's clear that he's not telling the doctor that he's not taking the medication. Because if he was telling the doctor that, they wouldn't give him the prescription. But I think the most important issue between the doctor and patient is accurate communication. You must let the doctor know the truth. the only person you're fooling is yourself. So I think it's important that the communication between the doctor and the patient is an honest one.
Okay.
Dr. Callender, um, what happens with the situation that every prescription that is prescribed, you get the side effects, and they've had to change it and change it and change it and change it.
Say that again. I didn't understand.
Okay, on the high blood pressure,
Yes.
what happens when every time they prescribe a new blood pressure medicine, the most common side effects, you get them all. And they keep changing it and changing it and changing the blood pressure medicine.
Yeah, well, I think that if you have side effects, that's a good reason to change the medication. And if there's no medication, and if every medication that you're on has side effects that are difficult, then you and your doctor need to identify an antihypertensive medication or regimen that is associated with the least amount of side effects as possible. And I think that is probably the only solution, because we know high blood pressure untreated causes so many problems that it's imperative that it be treated and controlled. As I mentioned, it's, if the other ways of controlling blood pressure are ineffective, if losing weight and eating the right food does not work, then then medication then becomes imperative, and then taking the right antihypertensive that is associated with the fewest side effects becomes the best mechanism.
Dr. Callender, is there any record about people who may not need the blood pressure medication anymore? I mean,
Yeah, that happens, and it's but you just need to follow that up and make sure that because what happens is that may be true for a while, but then after a while, sometimes the blood pressure problem comes back. So you have to monitor that and make sure that your blood pressure is staying under control. And that's one of the common problems, is that people don't monitor it. They may be good for a month, and then they forget about it, and they don't monitor it. So monitoring the blood pressure is something that is important to do because there's so many side effects from high blood pressure, and because it is a silent killer.
would there be what indication would let a doctor know that maybe we can take you off of the blood pressure medication?
Yeah, if it takes your blood pressure and your blood pressure is low, that's a easy way of telling that the medication is excessive.
Mm-hmm. Yeah, suppose if all of a sudden you develop a good exercise routine, you change your diet, and and then your blood pressure would naturally go down. How would a doctor know that? I mean, unless you go for a blood test.
That's why we talked about the importance of the doctor and the patient having honest communication, because
Okay.
that communication is critical. That information is critical because
I'm having a hard time hearing the doctor.
right, yeah,
Everybody else is coming out clear,
yeah.
and I can't understand what he's saying.
Yeah. Well, I don't know anything else I can do about it. This is a different computer, and
It may be your volume on your computer.
They said, how is it to go?
You
It's
got two
not that it's not high, it's not clear. It sounds muddled.
It's muffled.
Everybody
Yeah.
else sounds good.
I'll turn it down and see if that helps. Does that help any?
No, I think what will help if you get your mouth closer to the source.
I am as close as I can get.
Okay,
I'm
well,
as close as I can get.
while I got you, one question I had is the importance of doing a blood pressure history. In other words, a lot of questions that people are asking about side effects, et cetera, and if you should take it, if you should get off of it and all that kind of stuff. You have to carry a history into your doctor over a period of time, like a week, 2 weeks, a blood pressure history.
That makes sense, yes. And I think that's part of the doctor-patient communication. And
I do that from time to time.
Yeah, I've always kept a journal. I've always watched my nutrition. I've always done the 5 components. And when blood pressure was discovered with, my father was diagnosed first. And then I had some allergies and took some medicine per the doctor, over-the-counter medicine. And I noticed every year I would have the allergy, and then I started reading and reading and reading. And this is before I became a coach. And I found out that the allergy medicine over the counter cause your blood pressure to rise, because I noticed that before I was diagnosed, every year I would have an increase in blood pressure, and found out, I analyzed it myself and found out it was just happening. And so at that particular time at Kaiser, it was a different doctor, and he says, well, I have to put you on it. So, you believe in your doctor. So I've always, I keep a journal and I take a journal. What I am doing now is requesting my medical records, because I keep all my information down in a bag of all the prescription I've had. It's a bag, okay, that they've had to change me on. And so now I'm going to request my medical records, because I want to see how many high blood pressure medicine I've been on. It seems that my body seems, I'm originally from the Gulf Coast, and that's salt water. And I read an article somewhere that people that live in that area have a tendency for high blood pressure because of the water is so salty. But so now what I'm doing is I'm going to request my medical records, because I want to see how many high blood pressure medicine have they prescribed for me, because it seems like my body is so sensitive. Number one, it's sensitive to sodium, okay? So for years, I've always cooked with no sodium, but I know there's hidden sodiums in everything, okay? And it's either salt or sugar, okay? And so now I'm going to request my medical records, because I want to look back, now that I have the time. I want to look back and see how many medicine they have prescribed for me, because now I have a new doctor at Kaiser, and I want to make sure she's not prescribing some of the, she's
Same
in
ones you
the
had.
same, and she's friends with my old doctor, okay, who worked with me. We worked together to make sure that I didn't have these side effects. And so, and it just seemed that my body seems so sensitive to side effects.
It's a good remedy. I think getting the medical record is a great idea.
Thank you.
The more communication you have between yourself and your doctor and your healthcare providers, the better off you are. Any other comments or questions about that? Because that's one of the biggest killers of.
Yeah. A comment that I would have is that I think in many cases people don't put enough weight on their body mass index, because having a healthy weight can have a very beneficial effect on blood pressure. So sometimes it could be that people say, well, I'm eating right, I'm doing all the dietary suggestions, my nutrition is good, but it's probably not if your BMI is not in the healthy range of 20 to 25.
Well, that's a good point, because I had one doctor that came into Kaiser and he made a deal with me. He said, if you lose 30 pounds, now I don't weigh a lot, okay? He said, if you lose 30 pounds, which would take me back to high school in my freshman years, and I lost the 30 pounds. So, I have the correct numbers for that. So, I'm just using myself as an example, Darryl.
Right, I understand. And, I really sympathize because I wrecked my blood pressure with Sudafed, trying to treat allergies. And, that's the recommendation I got from my doctor, take Sudafed. And it's a horrible thing. And it takes a lot to overcome how Sudafed can wreck your body.
That's exactly was the medicine that they told me to take. Thank you.
Dr. Callender,
Yes.
well, do you have any idea if eating hard food, like peppery, real hard food, do they have any effect on blood pressure?
That's a good question. I don't know.
Yeah, supposedly it's hot peppers are supposed to reduce blood pressure.
Oh.
Yeah, hot peppers will pull out the inflammation, the anti-inflammatory out of your body. One of the methods I use for nutrition is the DASH diet. I've used that for years.
Okay.
And Dr. Callender told us in one session that they've taken the DASH diet and the Mediterranean diet, put it together and make the mind diet.
Okay.
I mean, these sessions are just wonderful. Yeah. They're excellent.
I eat a lot of hot pepper, but I was wondering if they have any effect on my digestive health.
Supposed to. They say it does. I'm not a fan of of those hot things because my system doesn't tolerate it well. But there are people who tolerate it well, and it's beneficial for some. Any of you want to comment on that?
Yes, one thing you have to be careful with anything,
Yes.
any consumption of food,
Yes.
is you have to go back to biblical. Everything in moderation.
Yes.
Because you got that acid on your stomach and you
Yeah.
don't want to overeat
Yeah.
peppers. It may help with your inflammation, anti-inflammatory, but at the same time, it may wreck your stomach. So moderation is the key for me for everything.
Yeah, the other key is preparing your own foods. You eat out a lot or you eat processed and prepared foods is going to be high in sodium, particularly the hot foods. If you don't prepare it yourself, it's going to be high in sodium.
Yes, absolutely.
Hot sauce has a lot of sodium in it.
Those are called hidden sodium. Yes. Hot sauce, soy sauce.
Especially Louisiana hot sauce.
Okay. Well,
Dr. Callender, we talked about what you might call family history of high blood pressure or blood pressure in the African American community?
Well, it's well known that families do have a history of hypertension, as somebody mentioned earlier, and it is well known that we have 4 times the likelihood of having hypertension than white folks. So it's endemic in our population. So we have to be as careful as some of you have already mentioned as to what kind of food we eat and liquid we drink. Okay, well, I think we've talked about that appropriately, and it's good we have such a intelligent group to bring up all of these good points. Now, this is an article on vaccine response in severe kidney disease, and I included this because some in our group who had kidney disease and some who have kidney disease. And there's been much talk about what is the impact of COVID on patients who have end-stage renal disease who are on dialysis. And it is well known now that they don't respond to vaccinations as well as other people. And so for this reason, looking at what happens to patients who have end-stage renal disease becomes very important. And the bottom line is that vaccination in the end-stage renal disease population is not as effective as in other people. And for that reason, they have to do antibody titer tests to determine if you have end-stage renal disease, whether the vaccination has given you the correct antibody titer. And if it has, that's fine. If it hasn't, then you would need to get vaccinated again until you get the level that is effective. And so I think it's important. And the other issue is that, and we've talked about this before, is that some centers, they will not transplant you unless you have already been vaccinated, because end-stage renal disease population has a high mortality rate and high morbidity rate with COVID-19 and with its variant, with the variation with the BA1 and BA2, so forth. So this is why I put this article in here, because it helps us once again appreciate the fact that diseases like end-stage renal disease, and if you're immunosuppressed for a transplant or immunosuppressed for cancer, that requires a different standard in order to ensure that you're protected against COVID-19. That's a summary of what this article is all about. And they have certainly now studied, you can see 12,000 patients. And early on, that had not been done. But now that has been done. And we know that it's end-stage renal disease is an immunosuppressed group of patients, along with those who are transplanted and those who are treated for cancer with immunosuppressive medicines. Any comments on this? Because I think we have a lot of people in our group who have had a lot of experience with end-stage renal disease from sort of another. Okay, well, we had talked about this previously, but I just wanted to bring it up again. Now, this is an interesting article about, we've heretofore said that 8 hours of sleep was required for good health. This is an article that is done in another country that has looked at people from outside the United States, especially from the UK areas, China, other places, and they identified that the ideal sleep was not necessarily at 8 hours, but somewhere between 7 and 8 hours. You can see the mean sleep was 7.15 hours, and they felt that the 8 hours was not necessarily the golden sleep, but that sleeping less than 7 hours was associated with all kinds of mental health issues. They're consistent that 7 hours a night was optimal for cognitive behavior. So anyway, any thoughts about that or reaction to the fact that 7 hours is all it takes? Any thoughts?
Yeah, I'm a 7-hour sleeper, and seems to work for me.
I'm an 8 hour.
I'm a less than 7 hour sleeper. Things work out okay for me too.
Dr. Callender,
4 or 5 hours, but I haven't always been that way. But
My average is about 4 hours every night.
Mhm.
So, Dr.
It's,
Callender,
Janice, is it straight 4 hours?
uh-huh.
Yes and no. Normally I get in bed about 12:30, 1 o'clock, and I can wake up at 3 and be awake for a couple of hours and then sleep another 2 hours. The average straight sleeping is no more than 5.
That is clearly not optimal. So
Can't hardly hear you, John.
I said that's clearly not optimal.
Yeah, I'm sorry. When you're talking about straight sleep, you don't have to get up, especially don't have to get up to pee. That's nocturia. Let's see. There's a good suggestion that you don't eat or drink anything after 6:30 p.m.
And you don't eat fruit after lunch.
Oh my, that's all I eat is fruit.
Don't eat after 6:30, and that will help with sleeping.
Yeah, if you don't eat or drink after 6:30, you won't have a tendency to get up to pee at night. That's nocturia. And if you don't get up to pee, you can stay asleep. It'll be straight sleep.
Yeah,
I
right.
don't get up.
Go ahead. Someone was speaking.
Mhm.
You say you don't get up what now?
No, I don't get up. I sleep through.
Straight through.
I sleep. I don't go to bed until midnight. I get up about 8 and just about 8 every day unless I have to do something. But my thing is with the sleep apnea, sometimes I fall asleep before I put the machine on.
So you
And
have
I'll sit in my chair and sleep all night long.
well, I don't think that I have a dear friend I'm working with. I finally got her out of the chair into the bed. But I agree with Darryl. Now, Darryl, I started off with the 6 o'clock thing, and I moved my time up to. I eat lunch and dinner at between 3 and 4. Okay, I stopped drinking water. No water after 6 o'clock. And when I coach, I tell people one of the resources I use said that fruit stops after lunch because that is a natural sugar. Okay, but you want now this 3 o'clock thing. Ever since I was a little girl, I was the only one getting up in the middle of the night at 3 o'clock. My mother said I was the only one that could see in the dark. Okay, so I've done that 3 o'clock all my life. But I get up, go to the bathroom, and fall right back to sleep quickly. So those are things you want to monitor.
Yeah, it makes a lot of sense about fruit, any type of sugars. Particularly, people snack on chips at night, and there's a lot of sugar that raises the sugar level. Whenever you're raising your insulin level, when your insulin level goes up, you feel a pressure to pee.
Yeah, Dr. Darryl, that's good information. I'm not a sweet person, but at night I'll get that craving, and it could be at 10 o'clock.
Well,
and generally it could be a cookie. It's not a lot, and I don't eat ice cream, cookie or a piece of cake. But late at night, yeah, I eat something sweet, and generally I have that broken sleep.
Well, you want to work on that, because one thing about wanting something sweet, we coach and we tell that what it is your body is asking for a nutrition. Some nutrition is being missed. What they're craving, that's a craving that comes in. So you want to look in, we are all an advocate for our body. So you want to look into that situation, because you don't want that sugar, because it go back to what Darryl just said about the energy. Okay. And so what you want is a continuation of that sleep, a good restful sleep, because that body need that to function on all parts. And so you want to work on that so that you get the right nutrition.
That's good to know. My eating habits are awful. And one thing my sisters get on me about, I don't drink water. My meals are crazy here lately.
What?
I can have a 12-ounce bottle of water right now, and tomorrow morning I'm still sipping on it. So
What?
the past couple of weeks, I'm trying to take in more water.
Yeah, water is your friend now.
Mhm.
Well,
This has really been a great conversation because I normally sleep between between 5 and 7.5 hours a day. But my water consumption, I drink water all during the day and all during the night. And I do see where I do wake up more when I drink more or when I eat something sweet. So this has really been a good, healthy conversation for me.
Mhm.
Well, the last thing I'm going to say on this subject is we go back to one of the articles Dr. Callender spoke about, and he was saying anything white. That was a grapevine saying way back, said don't eat anything white, sugar, bread,
Mhm.
you know,
Rice,
leave the white stuff alone.
Salt.
Yes,
rice, potatoes.
yes.
Yeah.
Flour.
I've been able
White.
I've been
What
able to conquer the desire for salt, but my main thing is sugar, and that's what I'm working on now. Is my sugar desires.
let me one thing you want to say to your body, your mind want to say to your body, sugar is not my friend. It affects dementia and a lot of other problems. So sugar is not your friend.
neither is a supplement. One of the things that we talked about in the previous study was that the time that your brain wakes up and decompresses is when you sleep. And so, in the long run, if you're getting less than 5 hours of sleep a night, in the long run, it interferes with your brain function, it interferes with many parts of your body. The other thing that you emphasize is a great thing is if you were not to eat after 6:30 every night, you would do yourself a great favor. Eat or drink after 6:30, and that's hard to do. But I remember one time I said that on a radio program, and they almost kicked me out of the room. But it's a good advice. So. But anyway, I think that this has been a very fruitful discussion to hear many perspectives. But anyway, these are just some points of view. This paper you have here talks about sleep more and way less. And the essence of this article is talking about the fact that when you eat a lot, very often that causes you to sleep less and you weigh more. And that the more you sleep, the less. In other words, eating a lot will cause you to gain weight. And if you sleep more and well rested, you're less likely to have an overeat. You're less likely to overeat. And that's the essence of what this article is saying, that you need to sleep. Sleep has an impact on the registers in your brain that impact what you eat and what you want to eat. And so one of the ways to address that is to have at least 7 hours sleep a night. That's easy to say. It's not as easy to do. So it's food for thought for all of you.
Overweight also contributes to sleep apnea because your overweight can restrict your air passages. So, losing weight can help you sleep more soundly. If you're in a sleep apnea situation, you may consider getting either an elevated bed or elevated pillow. That'll help open up the airways when you sleep.
CPAP is a good remedy for that. Now, this is an article that talks about what are the best antioxidants to prevent age-related dementia. So we have to recognize, let's say first that we really do not have a good treatment for dementia. And while we have drugs that we say are helpful, and that's the term you should use, helpful, there's still, we have no real treatment for dementia. And so they're talking about the kale, spinach, broccoli, and peas, and oranges, papaya, tangerines, and so forth, that have these compounds which are thought to be antioxidants, which are thought to reduce the dementia risk. Didn't say eliminate, said reduce the risk. And so this is something that you have to keep in mind as you're eating these things. Vitamin A, C, and E are thought to assist, but we don't have anything that cures dementia. So the prevention of it is where we ought to be. And there's some concern that perhaps these antioxidants are helpful. Any comment? Darryl, any comment on this?
Oh yeah, the antioxidants are great, but if you load up on sugar, then for all the steps forward that you took with antioxidants, you'll take 10 steps backwards with the sugar and you'll be demented anyway.
Yes, I totally agree.
You may or may not be demented because everybody who takes sugar is not demented, but we know it contributes to it.
Mm.
And the question is, why does one person have dementia and why does another person not? And when will we ever get a real treatment for dementia since it's so common? And it's something that research is going on. And these antioxidants, I think Darryl's comment is quite appropriate. That the antioxidants may not change. But I think it's dangerous to believe that we have an effective treatment for dementia. We have treatments for dementia that reduce some of the ways in which dementia presents. But right now, we do not have a treatment or a cure for dementia. And I think that's important. Now, I talked about this article because that you have in front of you, because we had just recently, I think it was in January, we had a big heart transplant. And it's interesting to note that we had 3 big transplants. We had big kidney transplants, both of those are still alive and well. And we had 1 big heart transplant. And the big heart transplant recipient died. And one of the things that we've always been aware of is that there's porcine endogenous endovirus, retrovirus, endogenous porcine retrovirus. And this virus is in the pig. And so if you have that virus that's transplanted along with the organ, then that virus may be what killed this patient. And so this means that we have to be sure when we do pig transplants that they're free of this virus. And this is possible. Porcine endogenous retrovirus is identifiable. And so we have to be sure that any of these pig organs that we use are free of this virus. Now, this is the first patient that has demonstrated it because xenotransplantation has just about ceased since the advent of HIV. And so we're now starting it again with the kidneys and so forth. The kidney patients haven't manifested, but this one case with the heart suggests that we need to be sure when we transplant again the pig that it's free of the porcine endogenous retrovirus.
Dr. Callender, could you call this a mistake in not being able to perceive that the pig had this virus before they transplanted this man's heart?
Yeah, I would call it a mistake. Yeah, I mean, that's one of this is experimental, as you know. And that's why it's experimental, because they don't know everything about it. And one of the things they didn't know was about the role of blessing and divine. Although previous we had previous knowledge of it, but in terms of testing for it before doing the heart transplant, in retrospect, is a mistake. Yes,
Oversight.
mistake. Let's face it. All humans make mistakes. Doctors make mistakes. Scientists make mistakes, and this is a mistake. Yeah. Any other comments about the new pig transplant? Since the initial kidney transplants were done last year in October and November, and those two patients are still doing well. So the question is, what is the future of xenotransplantation with the pig? With the kidney, it seems like it may be all right, but I think as John has mentioned, we need to be sure that the organ that is transplanted is free of protein endogenous retrovirus. Now, this is an article that talks about our obsession with fish oil fillers. As we talked about that they're good for you, and I think everything that has to do with fish is presumed good, and in general, it's desirable. But, this is an article that talks about the fact that they're taking out for humans something that is good for the fish, and that this may in the long term be a mistake. Guy, what's your thought about fish oil?
Well, as a vegan, I wouldn't take any fish oil, but everything that's in fish oil you can get with plants.
You can get with what?
You can get with plant-based foods.
So what about the old cod liver oil that your mama tell you to take, every day? I mean,
I would say, what
was
about
talking
it?
about-
Because with my annual physical exam, my numbers are great, and I don't eat any animal products, including fish products.
Okay, and I think that there's evidence that there's positive aspects of fish oil, and I think Darryl's point is unmistakable. That you don't have to have it. On the other hand, there's evidence that it is of merit, especially as it relates to cholesterol level.
Now, I would have to say that I came from the generation in the wintertime, my father made sure you had your olive oil. Okay, now that's the generation I came from.
Me too. Yeah.
And it was a total of 8 of us, and not 1 8 got sick. And we all, we had to share rooms and everything. So I am a believer in the olive oil. I even have, I even make sure that my grandkids get it. But maybe one day we'll all grow up and be like Darryl and be vegans.
Well, there's merit to all of that. There's merit to being a vegan. There's merit to not being a vegan. You decide what is best for you and your mentality and your spirituality. Now, this is an article that talks about the impact of nurses and what the pandemic has done to the healthcare profession, and especially nurses. And what this means for healthcare is frightening, because of the people that are trusted, the nurse is the one that is trusted the most. And so if you have fewer nurses, this is not a good sign for the future of healthcare. It's not to take care of you, but the person is with you all the time. is the nurse of the nursing aide. And so we need to do something about it to try to turn this around. And the fact that they died by suicide is, the suicide rate is increasing, and it's a sign of moral distress and burnout. And same thing is happening with the doctors. Yeah. So this is not a good sign for healthcare. Healthcare industry is a complex industry, and you get sick. You need to have an advocate to get into the healthcare system because it's very complex and very unfriendly. And so, and I think that the role of the patient navigator becomes even more important. That is the person who helps you get through the system, actually get into the system, and then after you get into the system, with your health appropriately. And there are many reasons why that is not the case for people who are over 65 and for people who are poor and people who are different ethnic groups. Any comments about that?
Yeah, there wouldn't be a shortage of doctors or nurses if there was free college.
Well, college is anything but free. What are we talking about? $60,000 a year for most colleges, which is frightening. So we've got the antithesis of free college. Then you've got the COVID stress and isolation and all that other stuff. And you see so much suicide. It's just horrifying to see. The old and the young killing themselves. Horrifying. Any thoughts about that?
Yeah.
No comment? Okay. We'll go to the next one
I'll
then.
be in trouble. That's all that means.
We are in good trouble.
Yeah.
This
Wow.
yeah. Somebody want to comment? Go ahead. Oh, no comment. Then this is an interesting article. You may wonder why I would put this article in here. But this is a physician accused with killing 14 critically ill patients with opioid overdoses. What it's about, though, is that you remember Dr. Death, the
Kevorkian.
Kevorkian, yes. What was he trying to do? Do you have any idea what he's trying to do?
Dr. Kevorkian, I thought he was helping people to die that were in pain and didn't want to live anymore.
Absolutely. That's exactly what he was trying to do.
Mm.
Matter of fact, he thought himself in the same category as Jesus Christ and those kind of people. He's trying to help people. And he felt that there are people for whom they had no peace. And he felt that the doctors should help them do that. That's against the Hippocratic Oath, though.
Right.
And so, as a consequence, he was in prison, and eventually died. But the issue of euthanasia and actually mercy killing and helping those people who have no relief from painkillers and sedatives and to help them down. So that they then found that this doctors who were accused of killing patients that they had physician assisted dying of suicide, as they call it. They found them not guilty. And the question is, as you know, there's some locations, some states in which euthanasia, and some countries in which physician-assisted death is approved. There's only maybe one or two states in the United States that allow that. But and I think DC is even getting close to that. And here comes that old painkiller fentanyl that is killing all of our OD people, opiate overdose people. So the question is, what do you think about doctor-assisted suicide and euthanasia? Is that something that is something that affects in some countries? Of course, they have requirements that you have to have certain diseases and certain conditions, have it approved by a medical group before you proceed with that. So what are your thoughts about it?
Dr.
I,
Clyde, weren't you on the Oprah Winfrey show with Dr. Kabuki?
I was. Yeah, he was a good friend of mine.
Yeah, they were on the Oprah Winfrey show together.
I remember seeing that. That's where I first heard about him. I'm gonna put that. I have that in my arsenal for my end of life because I don't want to suffer and I don't want to live a life that's not productive. And I think I should have the right to direct somebody, but I don't want somebody else making that decision for me
Well, so
against my will. And I think this doctor was deciding he was becoming he was deciding himself who should live and who should die, wasn't he?
yeah, and it's interesting that you would say that because
That's an altogether different thing to me.
well, I'm not so sure about it. The reason I say that is because there are circumstances in which prolonging life is distasteful to the patient and to the physician because you're not it's futile. You know, we talk about futility. In other words,
Right.
no matter what we do, the patient's getting worse, and our treatment makes it even worse. So that if you get in the situation, and I've been in a situation where you have patients, in spite of what you do, everything that you do is making it worse. So, what has been done in that situation? You back off and you withdraw the poisonous treatments, and some would call that withholding drugs. They call that euthanasia. Some may call it, and I think that's what this guy seems to be doing. These patients are not improving, and they seem to be worsening. And he took another step. One thing to withdraw. It's another thing to give somebody fentanyl.
Right.
That's what he was doing. But they found him innocent. It's interesting because the downstream effects of this, what impact will that have? And I think you put it well. That this should be the decision of the patient themselves, not the doctor in general.
Dr. Callender, that form that we were advised or encouraged to fill out about end of life decisions, that directive, what is it called?
Advanced.
The advanced directive.
Mhm.
It seems like that might be something that could be included in that, in that advanced directive.
That is the answer because in the advanced directive, as she pointed out, you say whether you want to be put on a ventilator, how long you want to be on a ventilator, whether you want to have dialysis, whether or not. And so these are things that an advanced directive takes care of. And so
Right.
if you've not done an advanced directive and put that in your last will and effects, then this is something that is food for thought.
Didn't the district vote a law a law about that and then Congress rescinded it?
Yeah, the district approved euthanasia, and Congress here rescinded it. But, yes, but the district did come out in favor of that. Yes.
Dr. Callender, what is your take on hospice as far as putting patients or deciding that a patient should go into hospice?
It's a very good question. I've had a chance to see a lot of patients in hospice, and in some instances, it seems as though their efforts uh, result in accelerating the rate of their death.
Mhm.
And so the question is that a good thing or a bad thing? Then we go back to the same issue of the last paper, and that is that prolonging suffering, is that good? Prolonging agony, is that good? Prolonging a life of pain, is that good? And so for me, the answer is if the patient is in agony all the time, then that agony should be shortened. And in many instances, what happens with hospice is that the period of agony is short. And to me, that if that's what the patient wants, that may be desirable. To me, it goes back to your comments about what is the patient's advanced directive say? What do they really want? Do they want to live on in agony, pain every single minute? So, in my perspective, it's up to the patient. So the doctor and the patient should talk about it, and then let the patient leave the desire to go into hospice or not. The actual issue about hospice is that you have to have a sentence that you will not live longer than 6 months. Now, that brings it into issue whether the doctor's always right about that. And no one is always right about anything. So there's a doctor judgment and a patient judgment. And I think that a mutual discussion should be held, and censor to this is what the patient wants. And also honest discussion between the patient and the doctor about what is the likelihood of survival, pain-free survival, agonizing free survival. Those are my thoughts about it. Let's hear your thoughts.
One thought I had, doctor, is sometimes a person is so bad off that they can't even tell you what the pain is like.
That's correct.
Mhm.
And I've been there. Yeah. So what do you do in that circumstance, John?
In that case, the mutual conversation is between the doctor and the family.
That's correct. That's correct.
And I brought all of this up because that's exactly what happened with my son. That's why I was asking what your thoughts were, because it was not the doctor that came to talk to me about my son, who had his liver was failing. It was not the doctor, it was a hospice person. I don't know whether she was a nurse or someone on the staff. I'm not really sure, but it was not the doctor. I guess she said she had talked to the doctor, but it was not the doctor that actually talked to me. But they were saying that there was nothing else they could do and that he needed to go to hospice. So I just wondered what a doctor would think. You've taken that oath to keep patients alive, you know. I just wanted to hear what a doctor's thoughts were on that.
Well, I think it is clear now that not infrequently the doctor will talk to the people in hospice, but to me, the doctor-patient relationship requires that discussion first to be with the family or the patient, with the doctor, and then subsequently you might have that. But without that happening first, it's problematic. I think that the doctor-patient relationship requires that the initial effort should be with the doctor and the patient, and or the doctor's if the patient is not able to communicate with the family,
Mhm.
and then subsequently with hospice. That's my problem.
Mhm. Okay.
Was your son put in hospice?
Yes. Yes, he was. And I mentioned on another one of the things that he was an alcoholic, and you know, at that time he had not been off of his alcohol long enough for them to consider a transplant. So,
Yeah, okay.
you know,
Yeah, the other question for me, Betty, is doesn't the doctor have to sign something to recommend that he go to hospice?
Usually, usually, and it sounds to me like that there's some missing communication between you and the doctor, because uh, the doctor will say to you, or should have said to you, that your son is beyond hope. Did they say that to you at all?
well, it was not the doctor. It was some staff member from the hospital that I'm sure they had talked to the doctor, and they brought the information to me that, you know,
To me, it should come from the doctor.
yeah, but it was not directly from the doctor. No, I'm sure the doctor signed off on it and all of that. After I agreed, because I didn't want to see my son suffer. So I agreed to the hospice, but it was not the doctor directly coming to me. No.
Yeah, in a lot of cases, Dr. Callender, there are doctors who don't want to, give the bad news, and they let somebody else do it.
Well, I think she asked my opinion on it. And my opinion is that there's a doctor-patient relationship that requires the doctor to communicate with the patient. If the patient is not communicable, not able to communicate with you, then you communicate with the family first. So that would be my preference. And I hear what you said, John, but that I don't accept that.
Yeah, I had a similar situation with my mom. We had an advance directive with her. At a certain point, she, with her advanced Alzheimer's, had stopped being able to eat properly, and they had a nurse, one of the nursing staff, and I might have been what you were talking about, Betty. They call it a palliative nurse.
Yeah.
Who prepares the family for, I mean, it's very, very upsetting. One of the saddest times in my life to have to face that.
Yes.
But now, I understand why they call it advanced directive, because that's some advanced thinking you have to really do. And I mean, nowadays, the possibilities are a lot more. Your options are a lot more than they used to be, as far as, the different levels, of treatment or system or whatever. Those types of decisions, we really didn't have to think about a long time ago. Now, with all the different options, it's a lot more complex.
Now, there's an exception to the rule. The exception is if you have an advanced directive,
that's what
and it doesn't require the doctor to speak, because now it's the patient that has made the advanced directive. In that situation, then the doctor just says to you, the patient has made the decision. Therefore, we will do such and such. So, if your son had signed an advanced directive,
no, he did not have an advanced directive. He did not have an advanced directive.
Okay, well, we'll back to
But you know what I'm saying is that even the questions that you go through in the advanced directive are now much more complex and a lot more different options nowadays.
Yeah, but the advanced directive does cover them. It covers it, whether you want to do dialyze, whether you want to do ventilate, whether you want to do not resuscitate. So the options are all in there.
Mhm.
Choose
And-
which ones that you want.
And then I had a privilege to be the care person for one of my church friends. And he had not done an advanced directive, but when his family got ready to put him into a nursing facility or an assisted living facility, they required an advanced directive.
Yes.
And the family had to make the decision because his mind was not where he could make the decision.
Right.
So his family had to make the decision about the advanced directive.
Yeah.
So
My mother and brother went under hospice. And one of the deciding factors with us was that when their quality of life got to the point that it would do more harm than good. And they also had the advanced directory, and they took out the advanced directory when they were of sound mind. So we decided that that was the best once they reached that point. And their doctors in both cases with my mother and my brother got together and explained to us what their quality of life was going to be and what the hospital was able to and not able to provide to them. And based on that information is when we decided to go with the hospice. And it was a good decision. That was especially for my mother. She got comforted, and I got my brother and I were also comforted. And with my brother, it was a good decision for him also, because we knew that the pain that he was going to endure was not going to improve his quality of life or get him back to any baseline that he used to be. And it was a good decision for my family.
yeah.
Okay. Well, I think that's a topic that all of us have to deal with since we're born to die. So those circumstances are certain. So it's just a matter of whether we're willing to talk about it. Okay. Well, I think we had a great discussion today. And is this the last one? John?
We have 1, 2, 3, 4 more after this,
Oh, okay.
but they're all based on COVID, I think. So
Okay. All right. This is an article about the Omicron mutation, and that's been the basis for a lot of discussion over the since January. And I think that this brings us to the state that we now consider this endemic. We have the Delta variant, we got all kinds of BA.2, BA.1, 2, and so forth. And we've all learned over time with the pandemic that with the viruses, the variants are going to come. And so the only question is, will the vaccination cover the variant that occurs? And will this result in us having a breakthrough infection? And will the vaccine keep us from being hospitalized and dying? And so this then is the reason why we talk about this booster shot, the second booster shot, and the likelihood of requiring an annual booster shot. And of course, now we have, we'll talk about Paxlovid, I guess, a little more, because this is something that is a new drug that for the first time actually kills the virus. The vaccine prevents the virus. The Paxlovid is the drug that kills the virus. And so this thing is where our future lies. So we've come a long way now. We've got a vaccine to prevent the disease, and now we have a medication that effectively kills the virus. And so this then becomes the important part of our present and our future.
Dr. Callender, there was an article, I think, in the Post regarding that the vaccine that was treating COVID, and it indicated that the gentleman who had his vaccinations and he took the, what do you call it? Paxlovid? What's the?
Paxlovid.
Okay, yeah. That he still came up with COVID, and they were saying, you know, I think the article was like, it's rare. I think it was called another rare virus puzzle, because the individual was vaccinated, was treated with that new pill, and still came down with COVID again.
Nothing is 100%. So, but we'll talk more about that. We're going to talk about Paxlovid as well.
Okay.
This is an article about what to do about the boosters, and also about congressional funding for paying for the boosters.
Yeah.
Because one of the things that we have done is we paid for that in the past, but it's not in the budget for the future. And so the question is, will Congress approve the billions of dollars that is required for that? You know, and of course the fact that we did have our 1 millionth death from COVID last week is important. You know? And I think it's a good example of our present. Nobody's wearing masks anymore. And we still have these transmissible viruses that are coming up. And so the question is, will they provide that $22.5 billion? And so time will tell. And as this article says, that in the fall, we may have as many as 100 million people who are come down with COVID infections. And so what are we going to do? And so this then is what we have to deal with in our future.
Dr. Callender, I'll tell you, if they don't pass that bill, there won't be enough of them left around to pass it.
Well, let's hope they pass the bill. So we shall see.
They can find money for war. They need to find money for the people.
I couldn't agree more. Right. So let's hope they do the right thing. Let's go to the next one. Yeah, and this is talking about what we've lived through. 6 million deaths in the world, at least, because it may be more than that, but at least 6 million. And of course, we are the largest death rate in the world with our million. And as we look at what's going on all over the world, one of the things is that we have to recognize this figure here is frightening. More than 40 countries, fewer than 20% are completely vaccinated. And this inequitable vaccine status, as well as the inequitable status of things in the world, in the globe. And as we talk about the vaccine, it's tough, but it's even worse when we talk about medications like Paxlovid, because that's not anywhere close to 10%. So the question is, are we going to be any more equitable about global vaccines or global COVID treatment? My guess is no, but because we can't even do the vaccine, how are we going to do the medication? And, the inequities that have gotten the way we are today sound like they will continue. But this is what you were talking about in terms of Paxlovid. except that this was looking at it from a different perspective. They're talking about treatment for long COVID, whereas the treatment, what we were talking about is having somebody with a breakthrough infection who didn't respond to activate. And that is a new entity that has not been researched yet. And so we'll have to see what happens with that. But Paxlovid is the new pill that you mentioned. That is the only antiviral therapy that we know that is effective by pill. Now, the monoclonal antibodies have been effective to some extent, but they don't have the success rate the Paxlovid has. And they talked about 80% effectiveness, but that's still not 100%. That's still the best thing that we've encountered. Any comments about that before we go on this article?
I think these drug companies need to bite the bullet, and they need to accept some of the responsibility for the stuff.
What kind of responsibility are you talking about? Responsibility, what do you mean? Clarify that so we understand. What are they responsible for?
I can't understand you.
What are you saying they're responsible for?
Well, I think they should be responsible for making these for doing these studies, and they need to take on some more of the money responsibility of these studies, and stop standing, with their cap in their hand asking for money from the government. They've made billions of dollars off of us and continue to make billions, whether we're well or whether we're sick. They're always making money.
Well, this is a capitalistic.
And they need to make some sacrifices too.
Well, it's nice for you to say that, but this is a capitalistic country, and the country builds on capitalism. If you had a sociological country, that would be different. Capitalism means that those who do those things get paid for it.
Right.
So that's.
But this is a national crisis, and people should make sacrifices. And I think those who have more should make bigger sacrifices.
Right. Okay, that's good. You've expressed your opinion. I was just pointing out that in this capitalistic society, we encourage people making money off of their successes, and that's why the government is paying for it and not the company. So it's not their responsibility is to come up with a drug that works. The government's responsibility is to find a way to pay for it. As long as we are a capitalistic society, that conflict will be ever present.
Dr. Callender, I have a question. In the post about that article, the gentleman who was taking that Paxlovid, he had been vaccinated and boosted, and I thought we said that pill was for those who had not been vaccinated and caught COVID so that they could treat it. And I was wondering why they gave him the pill after he had been vaccinated and boosted. And I thought, like they would say, normally, if you get COVID after being vaccinated and boosted, you might have mild symptoms. So I was wondering why they gave him the pill after he had been vaccinated and boosted.
He didn't have mild symptoms. So he did not have mild symptoms because you only need treatment if you have severe disease.
Oh.
Yeah. Because there are people who have died of the vaccine, but they're small numbers. But the indication for treatment is if you have more than mild disease. So if you have fever, chills, and you're short of breath, then you qualify to have Paxlovid or additional treatment, monoclonal antibody. So, but if you have mild symptoms, then you don't qualify.
Oh.
Answer your question?
Yeah. I was just wondering. I said, okay, he'd been vaccinated and boosted. Why did he have to take the pill? Because they just said mild symptoms, you just go home and stay away for 5 days from anybody and, you know, your symptoms will subside.
But he had severe symptoms. That's
Uh-huh. Okay, yes, that answered. You know, the article did say another rare virus puzzle.
Yeah, well, yeah. Well, the puzzle is that Paxlovid didn't cure it. So,
Okay, thank you.
our biggest mistake. This is an article. Art Kaplan, who's an ethicist, is looking back at it. You know, retrospectively, you can see the mistakes you made and learn from them. I think this comment is that the way we talk about things and the language we use is important, and we've learned how to say things differently. You know, because some people consider the fact that you have to have a booster a failure of the vaccine, I think in many ways it's how you look at it. If the vaccine, as you mentioned, keeps you from being hospitalized or dying, that means it's worked. I think initially the language that we used was confusing. And so one of the things that we have to be able to do is to be more eloquent and non-conflicting in what we say. And so one of the problems, the way we talked about, I think many of you in this program have talked about how confusing it is. Because, and even the last comment reflects confusion about why somebody would be treated for COVID after having boosters and everything. And so having more clarity in our language and is something we've learned, theoretically we've learned. I'm not sure that we've put that into practice that well. Testing is something that I'm not sure we've learned lessons adequately either, because now we have people who are testing at home and we don't know what's happening with those people who are testing for that. And so that's another area that we may have learned, but I'm not so sure we've learned as much as we need to learn, because we haven't been doing the testing that long. I think it's probably a month or so we had the availability of the home testing. The other testing has been available, but the home test now is available, and I don't think we've learned enough yet about that, but that's something we've got to learn. We've also learned how to filter and use filters better. For example, the airplanes and places that can afford it have filters that effectively eliminate the virus, but that's expensive and is not available everywhere. And then the final issue that we've not learned from, I'm not sure he mentioned it adequately in this article, is the global perspective on how few places actually have 50 to 60% vaccine availability. And that, I think, is one of the biggest obstacles, is the global inequity of vaccine, as well as the global inequity in testing. And so this is something else that we've got to work on. But so there are many lessons to be learned from. Of course, I think you mentioned first the language, which I think is something you've mentioned many times about getting confused about what is really going on, what is the purpose of the vaccine, what is the purpose of the different aspects of who gets the vaccine, who doesn't get the vaccine. I remember early on, there were inability to reach some people, some groups of people. And so we've made many mistakes, and you have to learn from every single one of them. And I think that is something that we've got to be aware of, and it's ongoing. It's an ongoing learning process, because we still don't know all the answers, but at least we're beginning to to see some of them. Because one of the biggest problems has been disinformation and misinformation,
Right.
and using the right language and getting the message across.
And Dr. Callender, to that point, one of the first things that we heard about this pandemic before it was acknowledged that it was a pandemic, oh, it's not that bad. It's just like the flu. You know, that was the first message that we got, which, you know, just made everybody just not pay that much attention to it.
Next thing, you don't need to wear a mask anyway.
Right, right. And that's
Yeah.
still kind of going on.
Yeah, I thought the doctor brought up some real valid points, and I was watching the video because he talked about that miscommunication and people going to local meetings and not having all the stats and quoting information about COVID, which they really didn't really know. But the other thing that pointed out was that he said many of the countries had already decided that you need 3 shots. And however we decided, well, get your vaccination, then you wait 4 months, and then you get another vaccination, then you wait another 4 months, whereas the other countries were saying you need 3 out the door, whereas we decided we're just going to do it gradual steps. And I was like, everybody else said 3, and we just took it very lightly.
That's not true. Everybody did not say 3. They didn't have enough knowledge to know. You know, some places did. But to say everybody did, that's not accurate, because we're ignorant of this disease. It's a new disease, and so we didn't know enough about it. And as we learned, we did different things. Different countries, Israel did this, UK did this, the other country did this. So it's a learning process. We didn't know it to start, but we didn't know anything. You know, we didn't have a vaccine. Let's face it, we didn't have a vaccine for the first 6 months. So we didn't know. No, so it's not accurate to say that. Although they said it's not accurate to say.
Okay.
I see in the article, it talked about preventive measure and fixing that preventive measure, cleaning.
Well, I think in the early days they did all that well, but it took them a while to do it. Just as you kind of said, it took them a while as they learned. I think one of the things that isn't appreciated is that we were particularly ignorant of coronavirus, and so we've learned a lot along the road. So that doesn't mean that anybody knew at the beginning that we knew what to do, because we didn't. We didn't even have a vaccine. We had nothing. All we had was the fact that we needed to wear masks, we needed social distancing, we needed quarantining and isolation. That's what we knew at the outset. Later on, as we made more mistakes, we learned. And we made many mistakes, and we learned from all of them. I hope.
Well, Dr. Counts, I thought I read somewhere where President Obama had given the incoming President Trump a report about the virus.
That's not about the virus, about any
protocol for if we had a virus.
Any communicable disease. He had a plan, yes. Trump denied it.
Yeah.
He said it didn't exist when it did exist. So Trump had his own agenda.
I see.
Are you calling President Trump a liar?
No,
Yes.
I call him a murderer.
I call him a villain.
Yeah, he's a murderer. He caused 1 million people to die because of his ignorance. 1 million.
And let's face it, the virus caused them to die. It wasn't Trump. He contributed to it, but it's the virus. It's a plague, you know. And plagues do that. Is that this the last one, or is there another one?
That was it.
Okay.
Yeah, he told me to take Clorox.
Sunshine. He said sunshine would clear it too.
Yeah,
Vitamin D, yeah.
Yeah.
Very sad.
Okay, well, we've had a great discussion.
He didn't succumb to his own medicine.
Yeah, was wise enough to go to Walgreens and get treatment. So,
Dr. Callender, we're gonna fix your sound next week.
no, hopefully I'll have my other computer back,
Okay.
because this has been a problem with this computer. But I had some issues, so I had to put it in the shop. Hopefully by next week I'll have it back. Because whenever I use this computer, the complaint that you guys had